Hello, good morning to all of you, and thank you for attending this CyberSight webinar. I wanted to start off like we usually do by thanking Orbis for allowing us to do these webinars. It's a great honor to be able to share the airwaves, if you will, with great panelists from around the world. In particular, I'd like to thank Andy and Lawrence, who are behind the scenes with doing a lot of the organizing for this session. I want to remind all of you to visit cybersight.org. There is a wealth of information, educational material, a huge library of ophthalmic information that is free for use. And I would ask you to take advantage of that. I am Malik Kahook. I'm professor and vice chair of ophthalmology at the University of Colorado. My subspecialty is glaucoma, although the topic today is going to be a little bit different than the usual webinars that I host here on this platform. The goal of this webinar in particular is to discuss special eye care considerations on the African continent. So this is a very big topic, and we're hoping that it's actually the first of many such topics where we cover different regions around the world. Some of the topics will include unique challenges and innovative solutions to care on the African continent. We'll talk about tips and successful models that have been used and perhaps some of the learnings of what not to do versus what to do. The unique challenges and innovative solutions are certainly going to be different from one region to another, and we'll try and take a deep dive into those with the expert panelists that we have here before you. I'm going to go ahead and share my screen here and start with a basic introduction on the three panelists. We're very lucky to have three ophthalmic leaders from the African continent to join us and share their expertise. Dr. Abebe is ophthalmologist and glaucoma specialist. She's associate professor at Addis Ababa University. And thank you for joining us. Chico Mathenge is known to many of you because she's joined webinars before and she's part of the Orbis team. She's an ophthalmologist professor and program director at Rwanda International Institute of Ophthalmology. And Dan Kiagi has also had webinars in the past and is a friend to Orbis. He's an ophthalmologist, medical director at the Innovative Eye Center in Kisii, Kenya. I want to thank all three of the panelists. And I'm going to allow all three of the panelists to take about 3 minutes to do a basic introduction of where they are, what they do, some of the challenges that they might be facing in their particular area, any unmet needs, or anything else they want to share with us. And then we'll get into the questions that have been sent in by the audience as well as experts around the world. So let's start off with you, Dr. Abebe.
Okay, thank you. First, I would like to thank Orbis International CyberSight just for involving in this very important discussion. And I'm also privileged to be here, with you all great people. And having said that, just coming to my background, I did my glaucoma fellowship in 2009 with Dr. George Space at Wills Eye Hospital in Philadelphia. And then after, as a glaucoma specialist, I have been teaching mainly residents as well as medical students and providing glaucoma service at the Department of Ophthalmology of the Addis Ababa University. And we have also established at my department a 2-year glaucoma fellowship program. And I directed that fellowship program for 3 years. And I have been also training glaucoma fellows in addition to the residency in ophthalmology. And additionally, I have been also providing training, particularly on glaucoma surgeries, hands-on training to residents and ophthalmologists in the other institution in the other parts of the country. And the other activities is we have glaucoma weight lab at our department, which was established in 2022. And using that weight lab, we trained mainly on glaucoma surgeries to ophthalmologists practicing in the countries and other ophthalmologists from the other African countries. And the other point is our department is a pioneer department in starting residency program in the country, and majority of the ophthalmologists practicing in in the country are graduates of the department, including myself. And this, and we have, as I mentioned, we have the glaucoma fellowship program, and the other program that we have in the department is two programs on sandwich fellowship programs on oculoplasty and anterior segment in collaboration. These programs have been run in collaboration with HCP, blind cure blindness. Having said this, just to mention, some of the challenges that I would like to mention is the other point. Just I want to mention as part of my introduction is I have been working with our Ophthalmological Society of Ethiopia on public glaucoma awareness since 2008. And also I have a private practice at UCHealth General Hospital in Addis Ababa. So after saying this, just the challenge that I would like to mention, this is a general challenge for all the the ophthalmologists practicing in our country. The number one is the challenges are for the several years or decades, as far as I know, a number of activities have been done on improving the eye cares with the involvement of the development partners. But as far as our country is concerned, our population is huge, and the country is also among the low-income countries, and the need for the eye care is still, there is a huge gap. So in this regard, I would like to mention the challenges are, one is the accessible and equipped eye care center, the limitation at all levels of healthcare, and the other is the trained human power at different levels. Still, there is huge limitation, and the other challenge is the availability, accessibility, and affordability of medication, especially those medications that should be taken for a long period of time, like glaucoma medications. And the other limitation that I want to mention as a challenge or limitation is, we know, the advent and the fast growth of technologies, but there is a marked limitation to access for the new technologies in our country, and I believe that applies for all African. So that I would like to mention. Thank you.
That's great. Yeah, and we're going to touch on many of those aspects that you just brought up. So it's a good way to make sure that we touch on all of those things that are top of your mind. So let's move to Dr. Chiku, and maybe you can do a similar introduction and let us know how things are working in your area of the world.
Thank you very much, Dr. Kahook. I am feeling a bit intimidated being surrounded by so many glaucoma specialists and such experienced one. My specialty is medical retina. So I am from Kenya. I live and work in Rwanda, and I'm quite familiar with eye care in both those countries. They are similar, but also quite different in many aspects. So I like to say I practice as a comprehensive ophthalmologist because that is really the reality of eye care in my part of the world. It doesn't matter what your subspecialty is, you will still do some cataracts every day. You'll still treat some allergic conjunctivitis, remove some chalasia, and hopefully you'll get a case in your subspecialty. So I consider myself very lucky that I have had a career that's taken me into academia, into the NGO world. As you mentioned, I am a medical advisor for Orbis. I've done the same, had the same role for Fred Hollows Foundation for many years. I am involved in research, and as I said, I am a full-time clinician. If you ask me what is on top of my mind today, my 13 residents who all have major international exams coming in June, and what I've learned is probably in all those roles that I've had, being a program director is the most challenging. but also the most fulfilling. When we graduated our first batch of 4 ophthalmologists 2 years ago, we increased the number of ophthalmologists in Rwanda by 40%. And that's very satisfying, and to realize that they were able to literally hit the ground running and working in district hospitals unsupervised. That has been one of the most satisfying aspects of my career. In research, one of my interests is artificial intelligence, and I've been involved in projects looking at screening, especially for retinal diseases using AI, and been very fortunate to have access to CyberSight AI, which is a free of charge product, and which I was privileged to be able to work with the developer and really get a product that was customized for my needs and could really solve my problem, which is a rare privilege. Usually we use what we get. But my research interests also go to school screening. So we have a major school screening project coming up in Rwanda, and my role in that will be right from training the screeners, developing the protocols, the data collection tools. So that's kind of how my everyday life looks like. I'm very honored to be the current president of the African Ophthalmology Council, which is like it's the supranational society for Africa. It's one of the newest. So this is similar to NIACO, APAO. This is it for Africa. And I'm the first female president, and very busy preparing for our first in-person conference, which will be held in Kigali, July 27 to 29. And I invite everyone in the audience to come and visit Rwanda. Rwanda is really quite a special country to visit. And just 2 weeks ago, I became the only African on the Academia Ophthalmologica Internationalis, which I kind of count up there as one of the things I feel very lucky to have achieved in my life. So yes, Dr. Kahook, Ramadan Kareem, and thank you for having us on this webinar, and thank you for choosing Africa to be the first panel that you have.
Yeah, that's amazing. Yeah. So thank you for all that you're sharing. And I've had the privilege of working with you on some of the AI work, and it's important to thank Nicholas and Gabriella, who are behind a lot of the AI infrastructure on CyberSight. And again, it is free for use for anybody who wants to go into cybersight.org, and I would encourage you to take a look. So last but not least, of course, here with the introduction is Dan, if you could take a couple of minutes just to tell us a little bit about what you're doing, and then we'll move on to some of the questions.
Thank you. Thank you, Dr. Kahook, for the kind invitation. I was born and brought up in Kenya, and I was educated in Kenya in the University of Nairobi. And that's where I met Shiko. She was actually my senior, even when I look obviously much older. I was actually born in a village, so we didn't have an opportunity to go to school on time. So after that, later on, I proceeded to Ottawa, Canada for Sandwich Fellowship in glaucoma under Professor Karim Damji. So in terms of my work experience, I've worked in the government of Kenya for a long time. I've also had the opportunity to work in the mission hospitals, Lighthouse for Christ Eye Center. Then later on, I joined the university, the Akan University Hospital, Nairobi. It's a private university in Nairobi, where I worked for a number of years, and I was the head of the Department of Ophthalmology. And during that time, I was quite involved in society leadership, both in the region and in Africa at large. And that gave me an opportunity to travel a lot, to attend conferences across the world and speak in conferences. And one of the most common topics I could be given to talk about was the opportunities and challenges for glaucoma care in Africa, or what can be done with the backlog of blindness from cataract in Africa. And being in a university in Nairobi, just doing a few faculties a week, I could obviously sit down and go through the Google and prepare the topic, and made my presentations good, and I could present very interesting topics, and I could feel like I have a solution, and I know what the challenges and opportunities are for cataract care, for glaucoma care. But when I come back to the university, I could feel very bad. because I'm sitting there, I'm in Nairobi, and I'm not doing much of what I said in the talks. And so I happened to come from about 300 kilometers west of Nairobi in this region of Kisii. It's a very densely populated area. And unfortunately, the ophthalmology care was very, very minimal. And I checked, and the CSR in that area was about 300-400. So, and even when I visit home, I just see a lot of blind people from cataract. And because I worked in Nairobi, I didn't have a way of taking them to my theater and operating on them. And I had nothing to do with about their situation. So that continued making me very uncomfortable. And as we, kept giving these talks, and I realized that if anybody has to do this thing, is me. So I resigned from a very good job in the university and headed to my home county and started an eye hospital. I thought the best model that I could do was a social enterprise, where it was try to give high volume, low cost, sustainable, high quality kind of eye care services. And I kind of felt, it was interesting to be involved in glaucoma, but I didn't feel like I was doing a lot in glaucoma, because even when I tried to do studies like teleglaucoma, I was just faced with cataracts. So I thought, however much I could want to do things in glaucoma, I think I need to focus on cataracts as well. So coming down to Kisii, so we started this with a lot of challenges, because there was not so much support, because it was kind of a private institution. There's nowhere to register a social enterprise, so you just register as a limited liability company, and try to use my savings and some support here and there and some loans. And they started the center with a shoestring budget. But I must say, 12 years down the line, I feel very good with what has happened. We've increased quite a bit. In this region, initially, we were covering about 2 million population of the community that I come from. And so now I've got 4 physicians who work for me, which is really great for a country in Africa to have 4 physicians for a 2 million population. And especially in the rural areas, got about 85 staff in total. And we do kind of about 400 operations every month, and reaching to the poor and ensuring that we are, reaching to the people who could otherwise not get these services. I think it's something which I could say is probably the best thing for the future in Africa. One of the issues that one problem I had in all the places I've worked, I felt like most of my bosses were not ophthalmologists, and they weren't understanding the things that I thought could make more sense to our practices. And I think that in a situation like Africa, where the systems and the institutions are not very well developed, I think it's important that the people who understand, like ophthalmologists, should head some of these institutions and do the things without being impeded by institutions and individuals, and the leadership probably don't understand so well where we're headed to and the problem we have. So this is where I am, and we're trying to expand and collaborate to cover more. I think in the next couple of years, we're looking to cover maybe about 6 to 8 million people. We're opening new branches and doing vision centers and outreaches. So it's going up, and still quite encouraged to be doing what I'm doing. Thank you.
That's great. Yeah, and I'm struck by how many of the topics that the 3 of you brought up that are part of our reality here in the United States on a daily basis. So there are a lot of things that are very similar, and of course there are things that are significantly different, and that's part of the learning process that I hope we're going to go through today. One of the reasons why I wanted all 3 of you to take some time to cover where you are is that there's this perception sometimes outside of Africa that Africa is a monolith, that Africa is a country, and that it's similar from top to bottom. I hear that, unfortunately, at some meetings that I attend nationally and internationally. But when you travel and you talk to ophthalmologists from the continent, you can see how different things can be from one area to another. So I appreciate all of you taking the opportunity here to express that to the audience. So I do have a series of questions. I also want to mention that a few people have helped with the list of questions. I got some help from Hunter Cherwick from Orbis, as well as Doris Macharia from Orbis, and a bunch of friends who are in ophthalmology who also sent me some questions that they wanted me to share with you. And this first question, I'll throw over to Chico from an educational standpoint, and then I'll ask for Dan and Abeba for you to comment as well. So the first question is, tell me about training in ophthalmology in your area. How do most clinicians go through training? What are some of the challenges, and what are some of the unmet needs in educating the future group of ophthalmologists in your area?
Sure, thank you for the question. So like in any other part of the world, ophthalmologists start off by being doctors, and in almost every country in Africa, the medical education is somewhere between 5 years or 7 years. It is expected that after that, you go and serve in a rural area, so you kind of pay back for your education by serving as a district medical officer. And many of the programs will not admit you for a subspecialty if you haven't done that 2 years of service. After that, you then join a residency program. A lot of ophthalmology training on the continent is run as Masters of Medicine programs in universities. And it's only in a few areas where there are fellowships. So there are colleges of education of ophthalmology that have been started in South Africa is one of the oldest, West Africa is another one, and now recently in our region also we have COEXA. And my own program is not under a university, but we are able to train fellows under a college. And those trainings can range from 3 to 5 years. After that, it's up to you to kind of sort yourself out and decide which subspecialty you want to pursue. There is very little subspecialty training on the continent, so most people will go out, and there's usually a dilemma between visiting a center like yours, Dr. Kahook, or going to India. And the dilemma is because we want hands-on practice, and we may not be able to get that if we come and train under you. So that's kind of where we have to make our choices. It is becoming increasingly unattractive for people to have to go out for 1 or 2 years to seek further education. And so this is kind of the time when we do need to start thinking about developing our own training for subspecialties. And a lot of the colleges are now working hard on that. They've developed curricula and are starting to recruit candidates. As Dr. Abeba said, she's running a glaucoma fellowship. Then the challenge in training is not just with ophthalmology. Ophthalmology is very unpopular in Africa, unlike other regions. So in my first year of running Rio, I admitted 4 residents. I only had 4 applicants, and I basically took what I got. Wow. It's becoming better. Last year, we did a joint recruitment with Dan, and I think we had about 70 applicants. And I think that's a bit unique. I would like to think it's because of the popularity of our program, but ophthalmology is just not that popular in this region. There is challenges in training the other cadres, so we do have a lot of gaps in service. If you ask me today, what do I long for most? I wish I had an orthoptist so they could measure all those muscles for me, and my job would be only to do the squint surgery. We almost have no orthoptists on the continent. Biomedical engineers, optometrists. Optometrists in many countries in Africa tend to work in the private sector. They run optical shops rather than being part of an ophthalmology hospital team. So I'll just stop there, but I think that gives you a flavor of the kind of systems that we have.
Yeah, and You raised also maybe another 10 questions that I need to ask. So this is, we could spend the whole webinar talking just about this part. So I want to go to Dan next because of the relationship that you have with Chiku's program. So it sounds like there's a joint training that's happening. So maybe Dan, you can talk a little bit about education in your area and how this collaboration is working, because it sounds like it's pretty unique.
Yeah, I think one of the best things that happened is for COEXA, I'm sure most of you know that this is a college that kind of offers training, about your training from wherever you are, whichever institution you are that is accredited. So now there's an opportunity that we can do all that. And the reason that I partnered with Chico is because our program was up and running and mine was a little bit coming up, so I wasn't ready to start on my own, so it was easier to partner. And that is the thing, the opportunity that we all have to utilize to increase the numbers. And a little bit on the subspecialty level, I think the time we trained, it was also a good opportunity to use a sandwich program, which I think Abeb and I used to train. I did that in Canada and Abeb did that in the US. And but as many of us now are back in Africa and working, and that was the idea of the sandwich program, that it gives you a chance to be more grounded in your country. So now I think people who are working in the high volume units have got an opportunity to also develop these subspecial programs. And again, under the umbrella of COEXA, which can accredit those programs and ensure that they're giving you. So I think a lot of credit really goes to COEXA for making, these opportunities happen.
Yeah, it's very, very interesting from a collaboration standpoint, how you can leverage the success and maybe the earlier start of another program to get yours up and running, and then you can feed off of each other and really help. So for Abeba, you have a particular experience with George Spaeth and getting some of your training here in the US. And how would you contrast that with what training is like where you are and some of the challenges that you might be facing from training the next generation?
Okay, thank you. It was an opportunity to be exposed not to what is being done in the Western countries, and with the great people as well. So it was not only Dr. George Spaeth, but there was other 8 great ophthalmologists there. So it was a great opportunity for me to learn from each of them. So, and then when just I was back home, what I have been trying to do is to apply what what I've been taught there in relation to my people with the setup we have. So I modified everything I saw. So almost I have been doing, my modified surgery. Usually I call my surgery a modified procedure. So it's really good to expose, to the great people. But what really matters is the problem you have in your country. The problem, it could be similar, but there could be a difference in different aspects. So when you bring your, your experience from abroad, it should be applicable to our community. So I have been working as well as teaching as to the existing condition in our country, the types of patients we have, the type of setup facilities, the machines, the equipment, operating microscope, the supplies, and everything. So everything should be based on what we have. So and I always like to do everything in a simple way, in a real way, and with what I have. Yeah, so this is my experience. So if you want me to talk about the training program in our country, currently we have 7 institutions with ophthalmology residency program. So nowadays the number of ophthalmologists is increasing in our country, which is great and good. But most of the ophthalmologists are working in the large cities. So when you go down to the communities, and even some regions, the number of ophthalmologists become so scarce or quite low as compared to the population. So there is this problem, existing problem. I think it's similar for most of African countries as well. The other is the residency program in our country. It's a 4 years training for the postgraduate. The fellowship, the sandwich is 1 year, which is good. Glaucoma is 2 years. 2 years. And we have also pediatrics fellowship on the way, and hopefully in the future we'll have a second university-owned subspecialty training in at our university or at our department. So I think these are the points I would like to say.
You know, the idea of not having access to ophthalmic care or any medical care outside of big cities is pretty ubiquitous around the world. And it might be augmented in specific areas like on the African continent because of mobility issues that don't exist to the same scale in the US. But we have the same issues with, even if you look at Colorado and Denver, main city in Colorado, we have a lot of ophthalmologists, but once you get into the mountains and beyond, we have a lot of patients who are driving in for care for a couple of hours to see us. So they're fortunate that they have the mobility to come and do that, but that doesn't exist everywhere. So for Chico, you said something that it's near and dear to my heart, and this is the idea of if you come in for training and you can't do hands-on training, how good is that training, right? So if somebody is coming to visit with me and they're shadowing me for a month, after the first couple of days, I feel bad because they're not able to do as much as they're capable of doing. And that's going to be a constant struggle for getting the right amount of training. How does that influence subspecialty care in your area? So where do people get their subspecialty care? And do you have subspecialists in every area, or it sounds like you're doing a lot of different things, and I'm sure the others around you are doing other things. So how do you cover subspecialty, and how do you get new subspecialists to be trained in your area?
Yeah, thank you. So, you know, you are absolutely right about the frustrations of observerships, as they're called, but I think they do have value. So I can give an example. I'm married to an ophthalmologist, and he did a cornea fellowship, and he I don't know whether it's a sandwich or what you call it. It's like a layer of things. So he did a bit of it in India, then went to Nepal, and then came to the US. And he always tells me that he's very grateful that that's the order that his fellowship went, because he already had enough of the hands-on training to really maximize his experience in the US by now observing kind of beyond what he already knew. And I guess that must be also what Abeba experienced when she did her fellowship. So nothing is useless when it comes to training. That's what I always say. Everything is useful. It just has to be timed well, and you have to be realistic about what opportunity exists in that different situation. So we do have only a few subspecialists in the country where I work. For some reason now, every African ophthalmologist wants to be a VR surgeon. Maybe because it was the great big mysterious subspecialty out there. As comprehensive ophthalmologists, we tend to be able to do a bit of glaucoma, a bit of cornea. So the only place where you do nothing is in the retina. The problem is that a lot of them come back home and they don't have the setup. VR is very equipment intensive, consumable intensive. And there are a lot of people who've been out for training and unfortunately are no longer practice vitreoretinal surgery today. So I think we have to be very purposeful in choosing what subspecialty our young people are going for. And I almost feel like the onus is also on the person giving these scholarships and opportunities to ensure that they support after training. I think it's really frustrating to be trained and then not be able to practice. Yeah, but because of that shortage, that's why we kind of all push ourselves to learn more and more skills so that we fill in those gaps which a subspecialist would fill. And I think there is great value in that model of just skill upgrading rather than doing full fellowships in Africa at the moment.
Yeah, it's interesting because there's the sandwich type fellowship that Dan did with Kareem Demji, which I know from talking to Dan was hugely valuable. But what you just described is a little bit different. It's more like a ladder that could be India, Nepal, US, or whatever might make sense, and then get a little bit of information from each. Some can be hands-on, some is more informational. Probably the most important thing with this is creating a network, people that you can call on. People where digital might play a role, cybersite where you're doing consults. It helps if you know the person and you can communicate more directly. Dan, just maybe a brief comment about your sandwich fellowship and how that worked. And are you still in touch from time to time with Kareem, and how does that work? And then I'll switch topics going more towards the healthcare system, but I just want to hear from you, Dan, about that specific experience.
I think the sandwich system that did with Kareem was very well structured, because we even wrote a paper about it. And the idea was that you get to know your preceptor very well, and he understands where you've come from. And then when you go there, you kind of spend the first few months, like 3-4 months, kind of trying to understand the circumstances of the work, the education, the research. And then you come back and you stay for 6 months or something like that. And during that time, it's important that your preceptor actually visits where you are. The idea is to, now that you know what can happen, so how do you get support in the place where you work to get some of those equipment, even if it's not all of them, but at least the most essential equipment. And I think the preceptor, then being maybe a more senior person, would encourage or source for them or talk to your seniors and be able to ensure that you've got the setup. So, and they work with you in your own setup so that you can compare how things go in the other setup and your own setup. And in your setup, you have more opportunity to do more cases, you have more opportunity to explore more things because you're more in charge. And ask more questions more freely because you have the preceptor there with yourself. And then you go back now to kind of take things to the higher level, so that at least so that when you finish, you are at the same level with the people who stay there the whole time. And you take, so that you can tie up the loose ends, and then after you come back, you still continue getting support in terms of visiting and sharing research and sharing ideas and producing papers together, and just checking that you've done the right thing. And then, of course, it proceeds to now getting other people with a like mind or like institutions to also send people for sandwich. And going towards the end, then you become, the person to take care of the students when they're back home here. So if they have, there's another fellow who has gone to the developing country, once they are back and the preceptor maybe is not able to visit all of them, so you can be able to be the one to visit and share your experiences and work with them. So I think it was a very good idea, and it was obviously enabling people to actually come back to an enabling environment where they don't have to feel so frustrated that I've been here for 2 years. It's a very nice place. I'm going back to almost nothing. None of these things are there. These systems are not there. The staff is not there. The equipments are not there. So you come back to an environment where you can thrive. And that was the whole idea, and it worked very well. But as I said, it should still continue in some countries, but maybe there are some countries where it should be phased off now as we increase the number of subspecialists in those countries.
Yeah, one thing that strikes me too in my travels, I'm spending a fair bit of my time outside of the country, visiting with different clinics and teaching, and in some cases operating, depending on where it is around the world. One thing that has changed over my 18 years in ophthalmology is that when I show up at a place, cataract surgery is pretty routine, and there are a lot of great cataract surgeons around the world. Whereas when I first started, I was teaching basic phaco. Now it's more teach me how to do a trab, or teach me how to do a Barvelt or a clear path or an AGV. So it's now much more focused on the subspecialty part and sort of the bread and butter surgery around cataract. we have a lot of very adept surgeons around the world. And of course, that continues to get better. It still needs some help in certain areas. But I think, from a Sandwich Fellowship standpoint or some of the other infrastructure that's been placed around education, a lot of it is around an individual, somebody who's leading, somebody like a Kareem Demji who's passionate about doing something like a Sandwich Fellowship. And I'll be interested to see in the future if we can take it more to the system level where you can use multiple people and it survives, even if somebody moves practice from one area to another or out of an academic center, similar to what Kareem did over his career. But let's switch gears a little bit and talk about healthcare delivery in general. And we'll go to you, Abeba, for starting off this question. So in the US, ophthalmology is often part of a subspecialty organization of eye care, but not necessarily tagged along to cardiology, gerontology, family medicine. It can be freestanding in a lot of settings, particularly, of course, in private practice. Is it the same thing in your area? Is ophthalmology ingrained into the healthcare system, or is ophthalmology sort of standing alone and not getting much help from the hospital system and the healthcare system in general?
Okay, I prefer to talk about the public healthcare system in the country.
That sounds
almost
good.
all of the eye care service, starting from down the community level up to the tertiary level, is with the other healthcare system together, just as part of like a hospital. So it's almost like that, and it's good to work together for the general care of the patient and to collaborate with the other colleagues in the other field. It's a good one, but there is I would say bottleneck. Why is that? Most of the time, eye care in general is is being seen as just a small area, like the eyeball. It's a small area which needs a small attention. This is the general understanding of by the other physicians. So if there is an eye department or eye clinic within a hospital, the opportunity or the attention given to that eye care is too small. This is really, this is what I'm saying. This is real. That is what has been happening in our country. So it's a big limitation. So, for example, in the hospital, Malik Hospital is it's a referral hospital where our department is situated. But even if the eye care is the huge service of the hospital, but still the attention given to the eye care is quite small. For example, there is one research which is a published one in one zone of the region of the country. In that study, what they have identified is the budget for the eye care of the whole zonal area is 0.7%. That's quite small. So this is a problem. So the other area that I would like to mention with this is this WHO strategy of integrating eye care, this integrated people-centered eye care, that to be integrated with the general health system. That's a great idea. A great one. But there should be an attention to the eye care. It should not continue as it has been if we want to change or improve the eye care in Africa. So just to improve the eye care, be it as part of the general health coverage system or not, the eye care system, I would say, should be a self-sustained one. Even if it is integrated with the other health system, it should be a self-sustained. If it is self-sustained, it can cover its own, it can cover its consume, it can have all the need equipment and many things. So it should be a kind of semi-autonomous, I would suggest. So in that case, every aspect of the eye care could be improved. So this is a huge problem that has been going on in our country. In the private sector, for example, just simple example, Dr. Chico was mentioning, retina surgeries are not being done in the public centers. for obvious reasons, because they need, very expensive and unavailable consumable, and they need machines, and these are not available in the public sector. So these cares, are being given in some of the private centers, but can imagine how many of the patients, how many of the diabetic patients, how many of the people with retinal problem can afford eye care service at the private centers. So this is a really problem. So I think it should be addressed, loudly.
Yeah, I think that last point, that's actually my next question, and maybe for Chiku. So how are patients paying for care in your clinic? And is there any semblance of a state national health insurance? How does that affect the way that you're delivering care and able to address some of the unmet needs from a healthcare standpoint?
Yeah, I'm kind of happy that question landed on me because, because Rwanda is really quite amazing when it comes to the way their health system is organized. And, as Kenyans, we don't like to say anybody else is amazing, but I've had to admit that. We have universal health insurance here. It's one of the projects that government is very proud of, very determined that it doesn't collapse even when aid is suddenly pulled away because of politics. Government always says the health system must not collapse. And so I would say about over 90% of Rwandans have some form of medical insurance, and eye care is included in the packages that it covers. So something like cataract, you can go into a district hospital and your health insurance will pay for your care. At the same time, if you are employed in formal employment, whether you're a policeman, a teacher, a professor, then your employer is obliged to provide you with a private medical insurance. So that's kind of the way it's organized here. And the challenge for us as eye workers is to make sure that we get as many eye care tariffs into those programs as possible. So one of the things I've learned is that as eye care workers, we have to be present, because if you are not there when those decisions and those things are being described, whether it's indicators for performance-based financing, whether it's tariffs for different procedures, you have to somehow find your way onto that table so that you talk about things in eye care. So that is not the situation in the whole of Africa, and a lot of eye care is from out-of-pocket payments, and that is a big barrier. And especially in a specialty where a lot of the care is in private clinics, as Abeba said, and it's in private clinics because of how much it costs to invest and set up. So that is a challenge. Within the health system, we have to kind of always fight to make eyes be felt. And I remember when I worked in Nakuru before I moved to Rwanda, the eye department was as neglected as Abeba said. And then I realized that the charge for any surgery in the hospital was the same because it was a government hospital. But then I also realized in one day I could do 20 cataracts, while my colleague, the general surgeon, could maybe do 2 fractures. And therefore my unit was generating a lot of money for the hospital. And when I realized that, I started, pulling my weight. For example, I wear size 7 gloves, and there were no size 7 gloves. Government hospitals tend to buy one size for everybody. Oh. And I remember one day saying, I'm not operating, I need size 7 gloves. And I didn't do surgery that day. And at the end of the day, I got a call from the medical superintendent saying, hey, what happened today? We have no money to buy gloves for maternity. And I said, what does that have to do with me? Or the income from our unit is what has been buying gloves for maternity. And I said, oh, I didn't have size 7 gloves. And he said, only. And from that day, I literally got what I wanted. So I think we do have opportunities to kind of be felt, even in a hospital where we are really looked down upon, but we have to identify where our strengths lie and be present at the decision-making tables.
Yeah, and sometimes you just have to speak up, right? Sometimes, as ophthalmologists, we also are not ingrained with the rest of the healthcare system. We speak a different language almost in what we do. As Abeba said, we're a small area within the body, and people think of us that way. But we do carry a significant amount of weight when it comes to the quality of life of the patient as well, which I think matters a great deal. Dan, I want to take this next one to you because part of delivering healthcare is getting patients to the clinic. You can do some things by digital, but a lot of times you have to get patients to where the healthcare is actually being delivered. And you mentioned that you moved into a more rural area. It sounds like there are a lot of patients there, but more rural. And I'm wondering about mobility and getting patients to the clinic. And have you done anything to improve access to get patients from more distant areas into your clinic system?
Yeah, thank you. I think that's something we're really doing every day. So it's good to discuss that here because, even when you are within that small community, you don't expect that people just walk in just because there's a good eye center there. So there's still a lot of social marketing one has to do, talk to them, build their confidence, know that they can get quality eye care, and find out what the barriers are. Some of them is just simply some health-seeking behavior that is, not acceptable. But you have to engage and find out what are the barriers. For example, we still do a lot of outreach programs, or what we call eye camps or eye safaris, and we did some little research to see what are the characteristics of this patient, and we found out that when we go out to the outreach, about 60 to 65% are women. But if people come to our hospital, because we have a high-level paying hospital where we have a phaco, if people walk in and say they want to have phaco surgery, it was the other way around. There were 65% men. So we figured out that there's some movement and communication issues with the women in the villages, so they could benefit more. And the same thing has happened with the vision centers that we have set in the communities. So we tend to get women from there more than men. And the people working in our hospital, we tend to get more men than women. And this is just data which is out there. And so some of the things we've done, even if it's in close proximity means the farthest is like 50 kilometers away, it's not obvious that they'll come. So we still do outreach, we still do health education on radios, we still try to get vision centers to places where they can get them nearby. We still work with what we call community health volunteers, who go actually sometimes house-to-house programs to tell them about eye care and then encourage them to go to the vision centers. We are especially doing that around the vision centers. When we set up a vision center to popularize it, we get the community health volunteers to go house to house and tell people simple things about eye care, and that if they have a problem, they can go to this vision center. And sometimes they take vision, and we have some 3 simple criteria for them to be referred. If they have diabetes, if they have poor vision because they take vision, if they have an obvious eye problem and swelling in the eye, or if they have an obvious cataract. So for those, they refer them, because that's quite simple now for these community volunteers to do. So we have to involve the community a lot. And it's interesting that with all that effort, we still feel like we are not in the CSR that is happening in India and other places. So it's an effort which I think is worthwhile, because a lot of success has happened with it. So there must be accompanied, obviously, with giving good quality care program in terms of the outcomes, in terms of how you receive them. Because it's interesting that the poor people, if you slide a poor person, they take it very badly. And when you slide another person of your same status, so you will be very careful to actually give very high quality care to the people, even if they can't afford, even if we have done the surgery for free, maybe with support from some donor or something. So, but they still get very high quality care and the top well of the institution.
Yeah. So it's not just trying to get people in. You've discovered that you also have to go to them and make sure that it's working both ways, which I think is the case with many, I guess, where the service is not as catering to a specific rural area. You can't expect that the mobility is going to be always coming in. You have to reach out. I'm thinking of parallels as I'm saying this, that Partners in Health in Haiti, for example, there's a pretty famous example of them not just creating a hospital, but also going out to the villages and screening and finding the disease and then bringing it in. So there are a lot of parallels outside of ophthalmology, I think, that also fit. Abeba, for you, do you have similar challenges from a mobility standpoint, patients getting in to see you? And in particular, not a fun topic to talk about, but also in areas of conflict. Unfortunately, there are some areas of conflict around Ethiopia. How has that influenced maybe some of the care with patients being able to come into different areas? I don't know if from a public health standpoint, if you have some insights on that, but answer any part of that might be comfortable for you. Oh, that's for you, Abeba. You cut out a little bit and maybe you didn't hear.
Yeah. Can you please repeat?
Yeah. So sorry, I saw your screen actually went out for a little bit. So, Dan just told us a little bit about mobility and going out to different areas to screen patients and find disease and do eye camps, eye surgery camps. Are similar things happening in your area? And how might conflict in the region influence the care of patients from a public health standpoint? Are they still able to access health care?
Yeah, the access to healthcare, generally it's good, but still as to the coverage, there is a limitation. So coming to the eye care, the far areas or, the areas, most of the areas are outside, the cities. The eye care service is usually given by the community eye care health workers. And there are also a number of campaign programs that have been carrying on mainly in partnership with this partners and the either the local or regional eye care service responsible bodies. So mainly the campaign programs are, they have been focusing on cataract. So that's a huge support to the public in general in terms of handling this #1 cause of blindness. But there are some limitations with this one. One is, such eye care programs are mainly focusing on cataract, and the other blinding eye condition can be easily overlooked. And the other drawbacks I would like to say is, people just living in far area, even people living in cities, they may wait until the campaign comes. So while they are having other blinding diseases other than cataract, because of just waiting, they may lose their vision, like glaucoma, just simple example. And the other disadvantage of such campaign that is the creation of feeling of as I mentioned before, the feeling of like eye care is a responsibility of the partners. Okay, so these are the points I would like to mention. So the coverage, as the need is huge, from community level to high level. The eye care need is huge. So to achieve that eye care system, there are many areas that should be addressed, like in terms of human power, in terms of the available service and the collaborative work between like the partners and the public and the communities. Yeah.
Okay. And Chiku, I want you to answer that same question, but also if you could add a little bit about technologies that might have been introduced or medications that have been introduced that have created the most impact on eye care. So it's kind of two separate things. Talk a little bit about mobility, access to care, and then in your tenure, both in Kenya and Rwanda, what has been introduced that really influenced and scaled up the eye care in the region?
Sure, thank you. Yes, I think access is always a big problem in Africa. You know, when I moved to Rwanda, I thought, I'm sure access is not going to be a problem in this country. It's small and everybody, you know, government is paying for everything. So how can there be a problem? And it's only after really getting to know my patients and doing a RAB, so a rapid assessment of avoidable blindness, that I realized, yeah, Rwanda is small, but it's very hilly and transportation systems are really difficult. And in many ways, it's much harder to get to a facility in Rwanda than it is in Kenya. So I think blind people getting to services that are very scattered is a problem everywhere. And sometimes they make efforts, they get to the service, but it's on the wrong day. It's not the day the ophthalmologist visiting, or the person who they meet at the health facility doesn't know anything about eyes. So when you ask about things that have made an impact, I think primary eye care training has really made an impact. And this is training of nurses who are in the frontline health facilities to know what to do with eyes. And you know, a few years ago, I was challenged by WHO to produce a curriculum for Africa. And it was a bit weird for me because I do medical retina, but I thought, okay. And what we produced was something that allows the nurse, and my feeling was, if a nurse can, you know, pull out a baby from a woman, surely they can treat a sticky eye. And so I divided the curriculum into things that nurses should be able to do, and things that they should at least give some first aid, and things that they should refer. And I have experience in Rwanda because we rolled it out across the whole country, 582 primary health facilities, trained 2 or 4 nurses at each facility. And we really saw the impact on numbers of patients now reaching the district hospital, where there is a trained eye health personnel. They just increased. And to me, that was the one program that really changed things kind of on a permanent basis, because the danger of eye camps and a lot of these partner supported programs is they have temporary high impact, but as soon as they stop, the impact also stops. So integrating things into the health system seems to be, it's slower, it might be more frustrating, but it causes more long-lasting change. I think we like to leverage on technology in Africa, and we are early adapters of everything, because if the technology fills a gap, it's probably easier to look for resources to get the technology than to train humans is very expensive and very, very, very tiring. So an example I could give is like, because our medical retina, diabetic retinopathy is of interest to me, and we don't have national screening programs in most of this continent. And when I got interested in a project that was supported by Orbis in artificial intelligence, I really grabbed onto it, because I saw an answer to this problem. Previously, if I had to screen people with diabetes, I have to go and sit at the Diabetes Association clinic. I have to dilate everybody, look at their eyes, refer them. But on that day, I'm not working at the hospital where other patients are waiting. And we don't have enough people who can look at retinas to be able to screen. But now we have a camera there with artificial intelligence, and I had to just train the general nurses there on how to interpret the results after they upload the funders' images, and you know, give them really basic interpretations of what that color-coded report is saying in Kinyarwanda. Translate that into a handout that the patient could look at and say, oh, so this is what all this red means. And we found that that really increased the uptake of people who do come for care after they are told you have retinopathy. So I think technology can be a game changer. The unfortunate thing is that technology is expensive, but expense should not be the barrier that makes us not take on technology in Africa.
Right. And potentially could save money down the road. If you're decreasing the burden of disease and decreasing the severity of disease, then from a quality of life and from an economic impact, it might actually make money at the end of the day for the system. So Dan, similar question, but sort of building on the artificial intelligence side of things. One of the questions that came in from the audience is, there's so many needs on the continent. Should we be focused on something like artificial intelligence, or should we be looking at other more basic needs? My answer to that would be, the answer is yes, we should try and do everything, and that AI does have a role. But I'm wondering, Dan, what you think about that. And then also any other technology that you want to share that you think has really been a game changer for you.
Yeah, it's always interesting listening to Chico. He's also my mentor, as I said. We know them embrace technology as much as she's done. We look forward to do that one time. Anytime we try to do that, we've always found both the hardware and the software very expensive. So, and especially thinking about where you're going to place it. So if you have to get a really good camera, we get a software that can really work very well, then nobody's giving you this. So that has been the challenge, but indeed, it's a way to go if this issue of hardware and the software can be resolved. Yeah. Having said that, so I think technology has to be there to help. I mean, you look at the phone, the penetration of the phone, the way it is gone. It's so amazing that everybody has a phone, and the phone can do amazing things. So when our friend Andrew came out with Peak, I mean, to me, it's the game changer. We have the opportunity to use it here, and very, very simple way of just taking the vision and then the algorithms which you eventually then feed in, so that you can see simply, even if you just simply see what is the vision people have out there. So we start from there. So and I guess it could be developed further and do other things. I think there's plans to do that. But I think, to me, at the rudimentary level of technology, I see things like Peak being the winner in terms of something able to cover widely and able to be used widely to diagnose, poor vision, whether it's from refractive errors or from cataract or from whatever, and simply inform these people that you have poor vision and that this vision is not good enough, and then hopefully direct them where they can get care. So I think because I mean, there are challenges in Africa in affording some of these things, in upgrading them, in using them properly, in maintaining them. So if something is there that can be widespread and be available easily and quickly, it's a Peak.
Yeah, it's been very difficult to try and find a mobile camera, a phone camera that is consistent enough that AI algorithms can uniformly gauge disease, no disease, referable, non-referable. I think Peak is one technology that is showing promise. But also, one of the issues is being solved by Orbis in creating an AI system on CyberSight that's free. So you can upload it and get interpretation that would be free. So the software part of it, I think, is being solved. The hardware is still an issue for multiple areas, getting quality photos that can be interpreted. So I think very good point, Stan. Abeba, you, of course, feel free to answer that same question about technology. And then I'm wondering if you can talk a little bit more about the human resources outside of ophthalmology that might be hindering care. So nurses, technicians, of course, we haven't talked much about optometry, which I think is super important to talk about, and all of the resources for eye care, whether it's surgeon, non-surgeon, ophthalmologist, optometrist, or technician. What are some of the needs, unmet needs in your area for that part?
Okay. Just regarding the technology, my point is, while just we are working for having the basic debating things or requirement for just to improve eye care service in Africa, we have to look for this technology, the new technologies as well, because, even if we have, so many limitations, we are people, we need quality care as the rest of the world. So I believe, we Africans, we need all the new technologies. So the availability, the cost issue may remain challenging, but we have to keep on working on that. So this is, I would like to, my comment on the new technologies. Coming to the human power, the human power we need, and they are very important. It's not only the ophthalmologist, medicine in general is a teamwork. And the eye it's the eye, the unique, and it needs a special care. So for this organ that needs a special care, we need trained people. The trained people, it includes, various cadres at different levels, like, community eye worker, assistant, nurses, optometrists, and the others. So we need all these people, at all levels. But when it comes to, to the real life, these cadres are very limited in them. Just simple example, in my glaucoma clinic, I never had an ophthalmic nurse. So it's a general nurse just who have been working with us, and they don't know, what's the eye, how to take care, how to measure the IOP, or all the question, the precautions when you're measuring the IOP and the others. Even in the OR, most of the nurses working in the OR are general nurses. So there is a huge limitation. And for another example, there is the one region that, they told me they have only one optometrist for the whole region. So there is a huge gap. As I said, the number of ophthalmologists is increasing, and we have 7 training institutions, but the other paramedics in the eye care, their number is quite low. So to implement this WHO strategies, and for just and all the points we have been discussing in for eye care in Africa, we need these cadres at all levels. So we need them in large number as to the proportion of the people. So these are equally important, even I would say, most important to improve the eye care, while while just having the assistance of the new technologies. The new technologies, they make just life easy. They may help in easily case detection, but unless we have the trained human power, the change or coordinated referral system with responsible bodies at each level of eye care, just to meet what we have been talking, it may be impossible. So we need to work on having all cadres in adequate number at all levels to improve the eye care in Africa. Yeah.
So Chiku, same thing here. Actually, we have a need for technicians, for more people in our eye center. So we are facing some of the same issues of the talent pool and where can we find people to join us? So I think it is something that we're all dealing with on some level. In your teaching institution, is it just teaching ophthalmology, or do you have recruitment and teaching programs for ophthalmic technicians, ophthalmic nurses? Do you have anything that covers that part of the need?
So thank you, Malik. But we do, but it's not our priority program. It's kind of like when we started residency training, it swallowed up everything. But we did start off as a training center for eye care. We have a cadre in the region, which I think is one of those innovations that come from Africa, called ophthalmic clinical officers, and or in the French part of Africa, TSOs. And these are non-doctors who are trained to do basic ophthalmology. And I would say in many countries, they are the backbone of eye care in Africa. So in Rwanda, for example, we have that cadre in every district hospital in the country. they are seeing many more patients than ophthalmologists will ever see. So when we started, I was interested in kind of gauging their standard against global standards. And one of the first programs we had at Rio was preparing them for JACAPO. I don't know whether you're familiar with JACAPO. It's the High Commission for Allied. And I prepared 3 cohorts for the exams. I'm very proud to say they all got through all their certificate exams. And that was very comforting to see that they could be at par with global standards. Those kind of allied personnel are really very, very critical if our populations are to access eye care. But like I said at the beginning, we do have gaps. When Rio started, we partnered with an Indian chain of eye hospitals, and I used to work there as a medical retina specialist. And the first thing I noticed is how good India was in completing the eye team. So for the first time in my life, I could do surgery, and before I even said what I needed, the nurse knew which instrument to hand over to me. And that Abeba is talking about nurses because they are just so important, and we don't have a lot of investment in training the other part of the eye team. I think it does need to be something that we prioritize. And for me as president of AOC, one of the things that I've done is opened up AOC to the entire eye care team. So our membership includes all the cadres. And when I asked them, what is it you want AOC to do for you? Everybody just wants skills training. So there is a real need at all levels. If someone needs an artificial eye today, we don't have oculists. So we just have to use generic prosthesis. So it's right across the spectrum. And my vision for Rio is that one day we will be able to offer the whole spectrum of training, because in some ways, those kind of short skills training are much easier than running a residency program.
Yeah, and they can feed off the residency program, and then you have multiple teachers that are in the same program, and it's a much more fulfilling experience when you have the whole ecosystem around you. So we don't have a ton of time left, and I wanted to touch on one topic that the whole audience, I think, can learn from. I do want to say thank you to the audience for some of the questions that came in. I think I was able to feed some of them into the general discussion, but this topic is so broad that I don't think there's any way we can answer all of the questions in 90 minutes. But just to close off, this is a question that I got from multiple colleagues in the US and also from outside of the country. And it's a common thing that people who are visiting other healthcare ecosystems wonder about. And that is, what do you wish, each one of you, and I'll start off with you, Dan, what do you wish volunteering doctors from overseas knew or did before coming and working with you? First of all, do you want them coming and working with you? And what do you wish they knew or did before coming to spend some time with you under the auspices of helping? They want to help in some way. What do you wish in that regard?
Yeah, I mean, I've been privileged enough to have many volunteers visited me, either here in TC or other places where I've worked, like in the Mission Hospital or in the university. And I think one thing that I've always wished, if I was to be told one thing, is that they should have a mindset that they want to develop a relationship. They should not have this free break for 1 week or 2 weeks and say, let's just go there and do that. And maybe there's some satisfaction they get, or there's some help they get, they give. It's like visiting some nice site, and then you go and you probably don't go there again. So Eyecare should be maybe a little different. When they come, they should have that mindset that they're coming here to meet people, to meet some situations that they could develop long-term relationships. Even if at that point they're not able to be there for a long time, like a month or 2 months, even if it's just a short time, then they should maybe then understand, with a name of understanding, what are the needs here? Which way can we work together? Are there some research opportunities? Are there some training opportunities? Is there some joint proposal we can make for funding? Is there some technology transfer that can be of long term? So that when they go back, then they still then can develop this further, and so that the relationship can be more beneficial, hopefully to both sides. If you're talking about research, if you're talking about research opportunities, and joint proposals, so that it can be long-term and mutual. So that's one I can see. I mean, there are a few other things, but that one stands out for me.
I think that's beautiful, Dan. I agree with everything that you said. And, there is this air of sort of being on vacation for some visiting people, that it's kind of the tourism and going to visit and not really delving in and making it a long-term relationship. And that's one of the concerns that I have when I'm visiting places. I don't want to visit 20 places and have a superficial relationship with 20 places. I'd rather visit a couple of places and go really deep in those places. But it's a struggle for both sides, for sure. Abeba, in your case, visiting faculty members, visiting specialists, what do you wish they knew, and what do you wish they might have done before visiting? Is there any prep or anything like that that you want to share, similar to what Dan was asked?
Okay, thank you. What should they knew is they shouldn't. So my suggestion is just to get information before they come to the area. Information, to the person they are going to meet, and information about the area, the community, the eye care service. So they may come with full mindset. So it's good, to know each other before they come, and to know what's the facility, what's the expectation, and to get, prepared and ready for that one. For the other point, I may take an example just to explain. And my example is Dr. Karim Damji. We met in 2006 during Orbis Flying Eye Hospital in our country. So our relationship started there then. And since then, his support was tremendous. I personally, even if I am formally, a fellow of Dr. Space, I am also a second fellow of Dr. Karim Damji. So he developed the Sandwich program to train, Africans in glaucoma, the Sandwich program. So in addition to the Dan and the other colleagues in Kenya, 3 of my colleagues, they got the training, the Sandwich Fellowship program training in Canada. And the other is he was, a major supporter in development of our glaucoma fellowship program, and also during the training, he was, one of the mentors with us. So his, his bond or relationship, it has been long time. So his support was in multi aspects. He supports us with equipment, with some of the devices, with education. He has been always in touch with us. So I would say kind of lifelong bond, from starting from one moment attachment. So I wish even the others to be like him. So it's a good example to mention.
Yeah, I wish to be more like Karim Damji. So we can't all be all that lucky. He's, I had a chance to visit him when he was still in Canada, and very sincere. And we have a lot of people in ophthalmology. I think we're very lucky in ophthalmology to have a lot of good souls who are seeing patients and working with each other. We're a small community, even globally, we're a small community. I think that's exhibited by how much you've worked with each other and know each other, and how much we've interacted in the past. So I think these are great insights. And, Shika, we'll go to you to kind of close off the session if you have any insights about this specific thing. So if I were at the end of Ramadan, I'm done with my fasting, and I have more energy, and I want to get on a plane and come and visit with you and do some stuff with you, in surgery and clinic, what's a perfect scenario for you with people who are coming to collaborate?
Yeah, I mean, I agree with everything that Dan and Abeba have said. And what I would say is, number one, ask the host. If I am coming to your house, I will ask you about any rules that you may have. So just that conversation, and I guess is related to the relationship, just ask me, what is it I need most? Yeah. And because that way you succeed and I succeed, and it gives you a chance to prepare the best for your visit. And don't prescribe what I need. Just let's have that conversation and we'll both thrive. So please come with your Kahook plates, and and I will prepare perfect patients who will benefit the most from that procedure. So that's what I always say. So if you're coming and you want to help me with cataract surgery, and you probably haven't done a manual small incision, which is what we would do when we go on outreach, then that shouldn't be your goal, because it will not be of great benefit to my patients, and it may be a struggle for you too. But I could say I will prepare a few patients for phaco, because I'm not that good in phaco, and you will do the phaco on one table and I will continue with the small incision on the other table. And that way we both end very satisfied, and probably you will get to teach me some phaco and I'll get to teach you some small incision. And my second point would be that every place in the world has rules, and just respect the rules that we have. And there's nothing like a free for all because it's Africa. Every country has almost identical rules to what exists in the West. To what extent people follow those rules, that's what changes, but we all need to be following. You must come and demonstrate best practice to me, even in my own country. And in fact, if I'm not doing things to the standard I should be doing, then point that out to me. But we do have rules about who can operate on what. So as a glaucoma surgeon, do not come and tell me you want to do oculoplastic, because right. This is the chance you have to touch a lump. Yeah. So I think that mutual respect is really important. And like today, Dr. Kahook, you have a panel from East Africa. If I was to visit West Africa, I do need to talk to people in West Africa and understand what are their needs. Because as you said at the beginning, we are a continent and we are extremely different. And everything we've described today here may be the correct picture for East Africa, but it may be completely different if you had a panel from West Africa or South Africa. So I think just having conversations and treating each other with mutual respect, then everybody thrives and benefits.
Yeah. So beautiful way to, I think, end the discussion. And it's really that idea of respect. So respecting colleagues from different areas, respecting the patient and the patient's needs, respecting culture, I think is super important, and maybe something we don't talk about as much. I think you also pointed out another dilemma for these sessions. So we're focused on East Africa, and it could be a completely 4 or 5 hour discussion in West Africa, Sub-Saharan Africa versus Northern Africa, talking to a surgeon in Morocco versus a surgeon who is in Rwanda. Very, very different. And it's actually one of the challenges that I have when I presented the idea of doing these sessions to the CyberSight team and had a discussion with Hunter Cherwick about it. It seems like a daunting task, but I think a necessary one. Can we go to South America next? Can we go to Southeast Asia next? And how do you get people together when it is very different? So it might actually make sense to have a panel of very different people from different areas and not just the same area. But we're going to play around with that and see what works the most. And as long as the CyberSight team allows, I'm going to try and continue to do these outside of the normal discussion that we have about how do I do my trab? How do I do my phaco? I think it's really important to learn from each other about delivery of care. I would encourage the three of you to send me a note afterwards on, what was done correctly, what could have been done better, what questions were good, and what questions I should have asked. To the attendees that are listening in, you sent in some wonderful questions that I tried to weave into the discussion. Please continue to give feedback so that we can get better. And maybe we'll do another session with the three of you with some of the follow-up questions in the future. So I want to thank all three of you for taking time out of your afternoons and evenings. It's the start of the day. The sun is out now here in Denver, but you're getting towards the tail end of your day. So I want to thank you for your time. Thank you, CyberSight and Orbis, again for hosting. And I wish all of the attendees a wonderful day. So thank you very much, everybody.
Okay, thank you.
Thank
Bye-bye.
you.
Yeah,
Bye.
bye-bye.
Bye.
Bye.